I'm Lydia Pecker, and I was going to start this session by just providing a brief overview about fertility in sickle cell disease, and particularly with attention to after transplant. And I've titled this a fairly nuance-free position because one of the challenges in describing the risks for infertility or preserved fertility after transplant is that we don't have a huge amount of data. But we have a lot of good reasons to think that fertility could be compromised by sickle cell disease. And so I just wanted to, by curative therapies for sickle cell disease. So I just wanted to share a little bit about that, my perspective on that with you all this morning before we hear from our panelists, Ms. Station and Mr. Moore, who obviously have really powerful insights about the experience of doing fertility preservation before pursuing curative therapy for sickle cell. Next slide, please. My disclosures are that I'm a consultant for Novo Nordisk and Global Blood Therapeutics. Next slide, please. So one thing that I think is important to establish is that when you're thinking about whether to pursue curative therapy for sickle cell, and you're thinking about particularly the fertility risks, I think it's important to remember that sickle cell disease itself and some of its treatments may compromise fertility. And so this is how I've been thinking about fertility risks in sickle cell disease over the last few years. The first is that sickle cell disease itself is, of course, a risk to compromising fertility. It's an infertility risk. And that's because, as many of you know, the disease is associated with complications that can prevent daily life activities like having normal sexual relationships and other aspects of life that are required to make a baby. For women with sickle cell disease, we're learning about how the disease and treatments affect the ovaries and are associated with changes in egg supply. And for men with the disease, we also see that sickle cell disease itself and some of its treatments can affect sperm counts. And this is important for thinking about fertility preservation because what you have to preserve will be based on the disease and also your exposure to treatments. So there's a lot of outstanding questions about how sickle cell disease treatments affect fertility. This includes the medicines we use for supportive care, like opioid medications, Tylenol, NSAIDs, all of those things we think about when we think about future fertility. Hydroxyurea, we certainly think about whether iron can impair fertility because of iron deposition in the ovaries or the testicles, or because of just how it affects the blood is not yet established. And we don't yet know anything about the new therapies, voxelotor, crizanlizumab, and L-glutamine. We have a little bit more information about the risk for infertility with preparative regimens for cure. And that's just because these agents have been used not only to cure sickle cell disease, but have also been used to treat cancer and to perform bone marrow transplants for other groups of patients who have different disorders. And so the reason that fertility is potentially compromised in sickle cell cure is because all of the regimens use alkylating agents, and we hope someday in the future this won't be necessary. But at the moment, all of the regimens for cure use alkylating agents, and some of the regimens for cure also require irradiation. Next slide. So I think it's really great news for our community that fertility has become a sickle cell concern. This is a reflection of the fact that people are living longer and better with their disease. But of course, it brings up new complications. And so it's really important that everybody gets personal and individualized information about fertility. We can't really make blanket statements about your personal risk for infertility. Some of the things that factor into considering your infertility risks are your age, the kind of sickle cell you have, what kinds of treatments you've been exposed to, and what kinds of disease complications you've had. And then, of course, fertility may be more or less relevant to you based on your family building goals, plans, and hopes. And for people who are post-pubescent, so have already achieved puberty, that's girls and women who are menstruating, and young men who've achieved pubertal stages, sometimes the semen analysis or ovarian reserve assessments can help figure out where you are in terms of your fertility. And we're still learning more about how to use those tests in care. And so it's important, if this is a concern for you, that you're talking to your doctor about it to get the information, again, that's individualized to you. And we know that access to fertility care is a major challenge for our community. We're not the only community affected by barriers to fertility care, but one of the barriers to getting people to getting these analyses done and to getting to fertility preservation preservation is cost and specialists available to provide the care. Next slide, please. And so I just wanted to make sure that everybody on this call is aware that there is, for the first time ever, a sickle cell disease fertility preservation grant available for people who are going through transplant. And that's because the costs of preserving sperm or banking eggs can really be quite overwhelming. And so the Sickle Cell Reproductive Health Education Directive has partnered with Be the Match, and you can go to the website and learn more about how to apply for a fertility preservation grant if this is something that you need to do before transplant. Next slide, please. I wanted to just be really clear that in the context of transplant, that these two things, the alkylating agents and the irradiation, are the two things that constitute infertility risks for this disease. And again, that alkylating agents are when you read the guidelines about infertility risks for children being treated for cancer, anybody who's exposed to an alkylating agent is considered to be in the future at high risk for infertility. And so that's sort of the basis for my opinion that everybody going through transplant should be offered fertility preservation and should be considered at risk for infertility. Whether that will actually come to pass or not is not established. Next slide. So sperm banking considerations. So first of all, the testicles can be shielded from irradiation. So if your bone marrow protocol requires irradiation, the testicles are shielded with a lead blanket so that they're not exposed to irradiation. And that's good for protecting sperm. People who take hydroxyurea and are considering sperm banking may need to stop hydroxyurea to let sperm come back so that sperm collection can be optimized. And because sickle cell disease also can cause sperm abnormalities, even after hydroxyurea is discontinued, it's possible that multiple collections of sperm will be needed to optimize the number of sperm that are banked. And as you're thinking through this process of banking sperm, the cost of long-term storage needs to be considered. Next slide, please. For women, it's a little bit, and girls, it's a little bit different. So first of all, ovarian tissue or eggs can be harvested for fertility preservation. So for men and boys, only sperm banking is a standard of care for fertility preservation. But for girls and women, both prepubescent and postpubescent girls and women can have a standardized option for fertility preservation. Unlike the testicles, the ovaries cannot be shielded from irradiation. And so it's more, they're more vulnerable to the irradiation damage if your transplant protocol requires irradiation. Whether or not to discontinue hydroxyurea use for people who are going through egg harvest is not established, and that becomes a personal decision and a conversation between your care team and your doctors and yourself. And the medications and process, which Ms. Station is going to talk to a little bit more, is a little bit more complicated for women because you have to take a series of drugs to stimulate the ovaries to make your ovaries make more mature eggs than they would during a normal menstrual cycle. And those medications can be costly if they're not covered by insurance. And they also follow a particular order and sequence. And so most people, no matter whether they have sickle cell or not, who are going through an egg harvest, have a care partner who helps them stick with all of the different regimens as they walk along. And not only is there a cost associated with harvesting the eggs, but just like with sperm, there's a cost with storage for the eggs. And so that's a brief overview of how egg harvest or embryo banking can go.